In this video, I will be discussing the clinical evaluation of COVID-19 patients. Let me begin with the case presented from Module 2. We will be digging more deeply into this case and describing how this patient should be ideally managed by the healthcare professional, keeping in mind that our understanding of this disease continues to evolve. Some of the details of this case have been changed to maintain confidentiality. This woman did not work at UF Health, but at another medical facility in Florida. For your admission history, I recommend including 4 key elements that make up the illness script. As illustrated in this sketch note I drew for our medical students. Epidemiology, illness pace or timing, key symptoms, and past medical history. First, epidemiology. Did the patient frequent public locations? Bars and restaurants are particularly dangerous. Was she exposed to sick contacts? Did she travel? What is her occupation? Our patient served as a respiratory therapist and was exposed to 3 COVID-19 patients without being able to wear the proper PPE, resulting in exposure to aerosol. Pace of the illness. Whenever possible, estimate the time of exposure and the onset of symptoms. Following exposure to an infected patient, the usual incubation period is 4 to 5 days before the onset of symptoms. Onset of symptoms can take up to 14 days. Early on, the symptoms tend to be mild, and 40% do not progress. 5 to 8 days after exposure, 40% of patients experience dypsnea, indicating moderate disease. At 8 to 12 days, 15% of patients progress to severe disease, and at 12 to 14 days, 5% become critically ill. In the case of our respiratory therapist, her illness came on in 3 days after exposure, suggesting a large inoculum of virus. Her symptoms progressed over 3 days, subacute. On being hospitalized, she rapidly progressed from moderate disease to critical disease over 48 hours, likely reflecting the high infectious dose of virus she received caring for her infected tracheostomy patients. Next, document the key symptoms and signs. Our patient began with a fever and later chills, followed by fatigue and a dry, hacking cough, and subsequently experienced dyspnea on exertion. The study reported of 1,099 patients with COVID-19 in the New England Journal of Medicine from China remains one of the most comprehensive studies of symptoms and breaks patients down into mild to moderate disease, light gray bar, severe disease, black bar, and medium gray combines all of the and reveals that fever is present at some time during the illness in nearly all patients. Dry cough is observed in 70%, and shortness of breath is seen predominantly in severe cases, 38%, highlighted by the arrow. Remember, as described in Module 2, a significant percentage of patients may not sense shortness of breath despite marked reductions in oxygen saturation. This has been termed silent hypoxia. Other key symptoms include fatigue, myalgias, headache, nausea and vomiting, diarrhea, abdominal pain, and 2 unusual complaints that strongly suggest this disease: loss of smell and taste. In my experience, if carefully questioned, a significant number of patients do complain of loss of smell and taste. I have also observed watery diarrhea in a significant number of my patients. In nearly all cases, multiplex PCR for GI bacteria and viruses was negative, strongly suggesting SARS-CoV-2 as the cause. Finally, it is important to document chronic diseases associated with poor outcome. Cardiovascular disease carries the highest risk of mortality, 10.5%, followed by type 2 diabetes mellitus, 7.3%, particularly when there is an elevated hemoglobin A1C. Chronic pulmonary disease, 6.3%, hypertension, 6%, and cancer, 5.6% mortality. As compared with those without underlying disease, the mortality is 0.9%. The CDC has recently added other conditions that increase the risk of more severe disease or death: obesity, BMI of 30 or higher, chronic renal disease at any stage, sickle cell disease, and patients receiving immunosuppressive agents, particularly transplant patients. Our patient had 3 chronic conditions: hypertension, type 2 diabetes, and a BMI of 33. On admission, her temperature was noted to be 102.6 degrees Fahrenheit, blood pressure is 125/59, pulse 95, respiratory rate 17, and oxygen saturation was 88% on room air. Her weight was 101 kilograms with a BMI of 33. She appeared moderately ill, demonstrating increased work of breathing, but no rales or rhonchi were appreciated on lung exam. The remainder of her physical exam was within normal limits. She was placed on 4 liters of nasal O2, and O2 saturations increased to 93%. Based on these preliminary findings, we can assess the risk of her progression from moderate to severe disease by using the NEWS2 scoring system shown in this chart. NEWS2 was developed by the National Health Service in Great Britain. This score factors in respiratory rate, O2 saturation, need for supplemental oxygen, temperature, systolic blood pressure, and heart rate, and the level of consciousness. NEWS2 is available on the free smartphone app MD Calc. Her score on arrival to the ED was 7 and predicted her deterioration. A score of 6 or higher predicts progression to severe disease with a sensitivity of 80% and a specificity of 84%. For COVID-19 patients, NEWS2 outperformed other risk scoring systems, including CURB-65 and QSOFA. What other factors should be used to decide on hospital admission? In addition to the presence of underlying disease, the patient's age needs to be considered. As shown in this graph of patients treated for COVID-19 in New York City, for ages above 50 years, there's a linear relationship between age and percent mortality. Men have higher mortalities than women. In patients aged 70 to 79 in New York City, mortality was 35% for men and 27% for women. These rates of death are considerably higher than reported in many other countries, 10 to 15%. Given these findings, when elderly patients, particularly those with underlying disease, are symptomatic enough to be brought to the ED, we strongly consider hospital admission for a minimum of 48 hours observation. On the day of admission, our patient's X-ray showed bilateral infiltrates, and her nasopharyngeal SARS-CoV-2 RT-PCR was positive. On the second hospital day, her respiratory rate increased to 38 and her O2 saturation dropped to 88% on a 100% oxygen rebreather. An arterial blood gas later demonstrated a PO2 of only 74 on a 70% FiO2 by rebreather mask. This necessitated intubation and ventilator support. She next developed shock and urine output dropped to 0 and anuria. On hospital day 6, she received convalescent plasma. 48 hours later, her blood pressure returned to normal, her renal function normalized, and her oxygenation steadily improved. And on the 18th day of hospitalization, after 16 days on a ventilator, she was extubated and has required over 3 months of physical therapy and has not yet returned to work. The right-hand image shows our patient's X-ray on day 2. As compared to day 1, you can see the marked increase in lung opacification consistent with the development of acute respiratory distress syndrome, or ARDS. When it comes to imaging of COVID-19, chest X-ray has a sensitivity of 89%, but a specificity of only 60%. Chest CT has a similar sensitivity depending on the severity of disease, ranging from 73 to 94%, being higher in severe disease. CT scan has a higher specificity, 79 to 84%, and can detect abnormalities even in mild disease. Here are 2 examples of ground glass opacifications commonly associated with leakage of fluid into the alveoli. The left shows a fine opacification in one lung field, and the right shows bilateral ground glass appearance. Disease can progress to more dense infiltrates and evidence of scarring and less commonly abscess formation, shown as the arrow. In COVID-19, infiltrates are more frequently seen in the peripheral zones close to the pleura. As we discussed in another instructional video on thrombotic complications, COVID-19 patients have a higher incidence of pulmonary embolus, and in patients with sudden onset of profound hypoxia, CT pulmonary angiogram should be considered. In summary, history should include the epidemiology, pace of illness, key symptoms and signs, and include an inquiry about loss of smell and taste. And finally, past medical history of chronic predisposing diseases should be obtained. We introduced NEWS2 as a helpful scoring system that can predict deterioration and the need for hospitalization. We also emphasized the importance of considering age and underlying disease in deciding on admission to the hospital. We noted that chest X-ray and chest CT scan are equally sensitive for demonstrating pulmonary disease in COVID-19. CT scan having a higher specificity, often revealing classic ground glass opacifications even in mildly ill patients. In our next video, we will be focusing on the laboratory studies that should be performed in hospitalized COVID-19 patients.